But we do have time for a couple of questions, and so I'm going to start up in the back there. Oh, actually, well, yeah, we can start up in the back there.
Heather, thank you. I really appreciate all the presentations. I think back, my dad was a physician, and he sold his practice the day before he died 20 years ago, and he was a single practitioner, an internist, a thing of the past. I'm not exactly sure how that connects, but to my question, which is, I realized the need to compete. 20 years ago, there were no advertisements for drugs. There were no advertisements for hospitals. Doesn't it cost a huge amount of money for DMC to be opening new clinics in Canton and Royal Oak? And I'm not questioning that you need to do this in order to compete. I guess what I'm questioning is this model of the need to compete. It just seems terribly inefficient when you're looking at the whole system, that you've got hospital systems competing with one another, building excess capacity in systems, and depending on technologies maybe superfluously, and et cetera. So if that question could be addressed, please. Thank you.
Thank you. I don't disagree with some of your comment. Certainly, the competition is difficult. To speak specifically to the strategy of our locations, however, that's very different in that I need to as the guy responsible for being sure that Children's is around for another 125 years. We can't perform our, the nuns, of course, who run hospitals have, the best saying, and that is no margin, no mission. We cannot do the sacred work that we have been charged to do if we don't make money. It's impossible. There isn't duplication of significant services at the children's hospital level. We are the only children's hospital in Southeast Michigan, unlike almost every other major city in America. Chicago has probably 5 or 6 children's hospitals. New York about the same number. Even St. Louis has 2 large major children's hospitals. So there's really not a significant duplication of the services that we provide, but I get the basis of the question. This is classic sort of cost shifting. You've got to find people who can pay for their care so that you can take care of people who can't pay for their care. Otherwise, there is no money.
Do other panelists have other comments? Yes.
I just want to raise the issue that, what you want to do is to have the community kind of decide what kind of health care supports they need, rather than corporations needing how much money I need and to be able to do it. And that's what we don't do well in America. We have an overabundance of hospital beds. We are working to divert people from emergency rooms. And, and one of my concerns that I raised at one of our meetings is that DMC is doubling the size of theirs, where we have some really good information coming out of research to how to keep people from using the emergency rooms. It's very cost effective and not very expensive at all. So you again look into the future and say, what are we doing, kind of thing. And it gets down to community planning around a community's healthcare needs and seeing that they have what they need. And then the question to me is whether or not we as a society can afford all of this confrontation if we are really doing some duplication and that sort of thing. And I think we really need to think about that. I think hospitals need to think about working and planning with communities about what they really need, and not building based on competing for a market share, but competing to meet the community's needs as the community has said the needs are, period.
Pretty much said what I was going to say.
Okay, I think Professor Hammer had a question.
Again, I want to thank all the panelists for coming as well. One of the themes that's been through today is the absence of community participation. So in the emergency manager discussion, one of the big concerns is where was the public? Where are the public? How do we get the public involved? I actually see this as a success story, something I've been able to observe for the last 3 years. I think because of the work of Marjorie's group and others, the constructive engagement through the Attorney General's process, that a much better agreement came through substantively, but it also established a pattern where community and providers were building a network of trust. And I think the sort of monitoring work that's going on and the work of the Legacy Fund actually is a success story that could be brought over to the other panels and learned from other communities. It really is community health. But I have a specific question, and this is for Dr. Gray. If you could respond to what Professor Jacobson was asking, how do we move the next step, which is really to try to meet the broader health of the children of Detroit, and what are some of the innovative community-based strategy in which people can partner with you and others to try to engage the health issue from that perspective?
Oh, so I get like the easy questions, huh? Yeah. As a general pediatrician who, was taught that preventive care is the most important thing that you can do, and who, spent, a decade or so, teaching anticipatory guidance to new parents about how to keep their kids healthy. What is said certainly resonates with me, and I endorse it and enthusiastically support it. The trick is how do you get from here to there, and in the meanwhile make sure that people are well taken care of, because today the reality in the city of Detroit is that I can name every private pediatrician in the city. I can count every private pediatrician in the city of Detroit on 2 hands and have fingers left over. The reality is that there is no one to do preventive care in the city, and that if the Children's Hospital isn't present to provide primary care, let alone preventive care in a real and meaningful way, or the pediatricians that are at Henry Ford Hospital and the handful over on the east side at St. John's, it ain't going to happen. And so it's good conceptually, but we're not there yet practically. Since I'm not running in the Republican primary, I suppose it's safe for me to say that I would also support a single payer system. My boss might go into a catatonic state if he heard me say that. I don't know, but I suspect not, just knowing his background. But until there's a really integrated, comprehensive system, a lot of these things are going to continue to fall short. Communities are overbedded in many places, certainly. There's can be a lot of argument about whether they're overbedded in our community or whether they're maldistributed in our community. My guess is that it's more the latter than the former, that the beds aren't where they need to be. I'm certainly knowing what's going on in my hospital right now. I could use another 50 beds. So it's and I suspect that there's some hospitals 15 miles away from me that aren't full right now. So I don't have a good answer to the last part of your question in terms of how do we get there from. I think it takes people smarter than me to do that.
I just quickly, I think there are potential advocacy opportunities through the community health needs assessment process. It's uncertain how to go about it, but clearly, assuming the Affordable Care Act is sustained, every nonprofit hospital must conduct a community health needs assessment every 3 years and implement the results. Community advocacy organizations can play a significant role in forcing the systems to conduct and implement the results.
Let me tell you one of the things that is most difficult. Dr. Gray, if you agree with this, well, then let's work together on this one.
Okay.
In the city of Detroit, we have several hospitals. What our organization has suggested, both through the Detroit-Wayne County Health Authority and some of the other groups, is why can't we stop competing on the assessment and do one assessment for the city of Detroit, pool our community benefits money, and you spend your money on this and you spend your money on this or whatever in order to start moving needles, rather than, we just have to put our egos aside and say, we need to do what is best for the people in this community. And we all have some money, and we know that we're not moving the needle on obesity and infant mortality and some things. Let's work together on this and not as competitors. I'll compete with you here, or I'll do this there, but let's get together and let's plan together and use our dollars as if it were one pot, although you may be implementing something or something else, And, you know, at this point, it hasn't been very well received.
Yeah, we would certainly be happy to participate in any venture to do a community-wide or truly community-wide, health assessment. I would be happy to participate in that as an organization. At least I can speak for Children's, absolutely. The expectation is that the responsibility for doing a community, I mean, there is an organization now that is responsible for doing that. It just doesn't happen in any really high-quality way. The state health department, of course, is responsible for assessing the state of health of the state, and the local health departments are responsible at the local level. Again, not going to happen, in any real quality way in the city of Detroit, or indeed even in the county of Wayne, and to a lesser extent happens in the other counties around the state. As long as there were meaningful, and that means put your money where your mouth is, commitment from the other organizations to do the same, and I'm not talking about the advocacy organizations, I'm talking about the health systems.
Help you push them if we can all.
We would absolutely participate. What we don't want to do is be yet again, the public, sort of semi-public charitable institution, and the others are just, standing by, saying attaboy.
Yeah. Let me take one more question from back there.
Thank you. Detroit, of course, has a significant underserved population, people that are not insured, underinsured. It is, and I, too, am all for a single-payer system, which isn't likely, it's not likely that's going to happen, but or to have some other mechanism to pay for people that don't have insurance that need preventive services or less expensive services. All of that also doesn't look like it's coming anytime in the near future. So my question for Dr. Gray is, how in the world is Vanguard going to be able to do this? How is it going to invest in all of this infrastructure in building and, sooner or later have to pay taxes, but not cut essential services, not cut education, not cut research? I mean, the leadership of DMC is a smart leadership, and I'm sure they thought of some of these things before. How in the world is Vanguard going to be able to do it without cutting services? Is first part of the question. Second is, in other parts of the country where Vanguard took over hospitals, what was the experience there?
The first question. My initial reaction, and many of my colleagues' initial reaction, those who worked at the DMC, particularly in leadership positions, was, who are these guys? They have to be idiots. So we're going broke, and they're going to come and buy us because they're for profit. I got an MBA, and I didn't still quite get it. But not to be flippant about it, but it's a wonderful question, and I think time will tell. But one, this is a company that's still in growth mode, and so they're acquiring assets, as it were, to sort of gain critical mass, because the belief is that, as Professor Jacobson suggested, that if you don't have scale, you're going to have a lot of difficulty playing in the future environment. And so, one, they need scale. And then you get the benefits of having a national system as opposed to a local, even if it's a large local system like ours is. And so that's part of it. Secondly, they have acquired not just hospitals, they have acquired a relationship with a first-class medical school. They have acquired a smart, if I do say so myself, leadership team that has managed to survive in spite of predictions by many that it would not happen, and not only survive but actually still provide quality care that's nationally recognized. And so they can use that asset of the Detroit Medical Center to benefit their San Antonio market, their Arizona market, their Chicago market, their Boston market, and whatever future markets they go into, and use the intellectual capital that exists in Detroit to benefit the rest of the system. And that's a big part of their intention. And from my very selfish vantage point, children's hospitals across the country, the large, freestanding, independent, not in a system children's hospitals, have been unbelievably successful, both from a quality point of view as well as from a just making money point of view. And so they're intrigued by that possibility as well. The second question which I've already forgotten in my 60s, pre-senility. Please repeat for me. Yes, the experience in the other markets. They've been in San Antonio is their first market. The company's been in existence since late 90s, I think, 98, 99, and the San Antonio market was the first place where they really, bought a large system, and that was the Baptist Health System, owned by, the Baptist Church, and so that clearly, that was a non-controversial acquisition as well, certainly, there. And they have built, not sure if it's one or two new hospitals. I think one new hospital in San Antonio, remodeled several of the others, and the system is not doing as well as the Detroit Medical Center is, today, but it's doing quite well and generates revenue for the bottom line of the corporation. Arizona is doing well. Much of the money in Arizona comes from they own a Medicaid managed care company. They own an insurance company, and much of the profits in Arizona come from that insurance company and not from the hospitals per se. Chicago is a work in progress in that they just purchased 2 or 3 more hospitals to add to the 2 or 3 that were there, but they see that as a promising opportunity. And their hospitals, they have nothing like the Detroit Medical Center any place else in the country, an academic medical center. But the hospitals are all sort of meeting their expectations, whatever those expectations may be within the corporation. But most importantly and relevant to this conversation is that if you ask citizens in San Antonio, and I have asked my peers around the country where there are children's hospitals and Vanguard exists, so what kind of corporate citizen is this healthcare company? Do they do what they say they're going to do? Do they put their money where their mouth is? Are they really committed to taking care of everybody? And my experience has been, and the conversations have all been affirmative.
Okay. Does the panel have any other thoughts about that? I think we're out of time for questions on this panel, but I want to thank again everyone who participated, both the panelists and the people who asked good questions, and let's please give them all a round of applause.